Welcome back to Bookfulness. This is episode 9 of our deep dive into human anatomy. In the previous deep dive, we spent our time exploring the intricate relationships within the axilla and detailed the simpler but certainly powerful musculature of the arm.
That's right. And today, we move distally, leaving the relative simplicity, you could say, of the humerus behind to explore the complexity of the forearm.
Okay.
We're guided again by Chapter 3 of Moore's Clinically Oriented Anatomy, 9th edition, specifically pages 418 through 460 this time.
Right.
Our mission really is to move past just identifying structures. We want to truly understand the sophisticated framework, the mechanics of rotation, pronation, and supination, and the incredibly dense neurovascular network. This network powers the critical link between the elbow and the hand. The forearm is where the engine for all that fine manipulation is housed.
Yeah.
And it's also a region where nerve and vessel vulnerability becomes really paramount.
I'm ready to unpack this. The arm, like you said, felt functionally maybe a bit easier to grasp. You had the flexors in the front, extensors in the back, pretty straightforward.
Pretty clear compartments, yeah.
But the forearm introduces this whole dynamic world of pronation and supination. Plus, you've got the stack of muscles controlling, what, 20 plus tendons heading down to the fingers?
It's a lot.
It just seems like the density of function here is, well, exponentially greater.
That density, it's built on a very specific mechanical foundation. Well, the forearm is fundamentally different from the arm because, as you know, it contains two bones, the radius and the ulna.
Right, not just the one.
Exactly. And the text describes this skeletal arrangement quite perfectly, I think, as a two-unit articulated strut.
Okay, articulated strut, what does that really mean in practice?
Well, think of a strut as a supportive frame, right?
Mm-hmm.
This one is articulated because the two bones, the radius and ulna, can rotate relative to each other. That's what allows the hand to turn palm down without you having to move your whole shoulder or elbow.
That structural difference compared to the arm is immediately apparent then. In the arm, the humerus had its head proximally, connecting to the shoulder.
Yep.
But here, the two bones seem to almost flip roles, depending on which end you're looking at.
That's a perfect observation. It's a bit counterintuitive at first. So at the elbow, the proximal end, it's the head of the radius that articulates with the capitulum of the humerus.
Okay.
That's what allows it to pivot for rotation. Meanwhile, the ulna, with its olecranon process, forms the primary hinge joint with the trochlea of the humerus.
Right, the main elbow hinge.
Exactly. But then conversely, down at the wrist, the distal end, the head of the ulna, forms that little bony bump you can feel, the styloid process. While it's the radius that primarily articulates with the carpal bones of the hand. So the radius becomes the main weight-bearing connection between the hand and the rest of the limb distally.
So the radius is kind of the workhorse bone, structurally speaking, especially at the wrist end.
You could say that, yeah. Especially for transmitting forces from the hand upwards.
And connecting these two bones, allowing that rotation while keeping everything stable, is the interosseous membrane.
Ah, the interosseous membrane. It's absolutely indispensable. It's this sheet of thin but really tough fibrous tissue running between the shafts of the radius and ulna.
So it's more than just tape holding them together.
Oh, much more. While fundamentally, yes, it's a ligament tying the bones together, its function goes way beyond simple adhesion. If we think bigger picture, it acts as a critical force distributor.
How so?
Well, when you, say, push down on your hand, like doing a push-up, about 80% of that axial load goes through the radius up to the humerus.
Okay.
But interestingly, when you lift something heavy or fall on an outstretched hand, the force is transmitted from the radius across the interosseous membrane to the ulna.
Ah, so it shares the load.
Exactly. It helps stabilize the entire forearm unit, distributing those forces.
So it's not just a tether, it's like a biomechanical shock absorber and load transmitter. It makes sure the forearm acts as one coordinated unit, even during that complex rotation.
Precisely. And functionally, don't forget, it provides huge proximal attachment sites for many of those beat muscles we'll get to,
Right.
the ones we rely on for fine motor control. Without that membrane, the deep compartment muscles wouldn't have nearly enough leverage to work effectively.
Okay, that makes sense. Let's look at the organization of the muscle groups that originate from these bones in that membrane. Just like the arm, the deep fascia of the forearm, the antebrachial fascia, And these intermuscular septa divide the whole region into defined functional spaces.
Compartments.
Yeah, and that structural partitioning is absolutely key, not just for understanding function, but also pathology, like compartment syndrome.
Right.
We basically have two main compartments. There's the bulky, highly specialized anterior compartment, which is our flexor-pronator group, generally focused on flexing the wrist and fingers and rotating the palm down pronation.
Okay, flexors and pronators in front. And opposing this on the back is the somewhat smaller but equally essential posterior compartment. This contains the extensor supinator muscles. They extend the wrist and fingers and turn the palm up supination.
Got it. So focusing on the anterior side first, the source material Moores clarifies that these flexor-pronator muscles are stacked. They're in three distinct layers: superficial, intermediate, and deep.
Yes, it's almost like a functional depth map. Generally, the deeper you go, the more specific the control becomes over individual digits or movements. You can see a nice overview in figure 3.61, ###B. The superficial flexor layer, 4 muscles. Now, the superficial layer muscles, they're kind of unified by a common characteristic. Almost all of them share the common flexor origin.
Which is where?
That's on the medial epicondyle of the humerus, that bony bump on the inside of your elbow.
Ah, okay, the source of golfers' elbow pain sometimes.
Exactly. Medial epicondylitis often involves inflammation right at that common origin. And because they originate there, it means they cross the elbow joint.
So they can act on the elbow too, not just the wrist and hand.
Precisely. They have the ability to influence both joints.
Okay, so what stands out to you in this most visible layer? Let's walk through them, maybe lateral to medial like the book does.
Sounds good. First up, moving from the radial thumb side towards the ulnar pinky side, we have the pronator teres. PT?
Name says it all.
Pretty much. Its name perfectly encapsulates its primary job: pronation, doing the palm downwards. But here's the interesting clinical note. It's not the primary or initiating pronator.
Oh.
No, it's more like an essential assistant.
Mm-hmm.
It really kicks in when you need more speed or more power for pronation, helping out a deeper muscle we'll meet later, the pronator quadratus.
Okay, so PT is the power pronator. Next, moving medially.
Next is the flexor carpi radialis, FCR.
Right.
The FCR is usually quite visible on the anterior wrist. Functionally, it's versatile. It flexes the wrist, obviously, but it also ducks the hand, pulls it toward the thumb side, or a radial deviation.
So like when you're hammering a nail, maybe? That kind of motion.
That's a good example, yeah. That radial deviation is crucial for movements like that, or maybe pitching a baseball. Its tendon is also a really indispensable anatomical landmark at the wrist. If you find it, you know where you are.
Where does it run relative to the next one?
It runs just lateral to the tendon of the palmaris longus, if it's present.
Ah, speaking of landmarks, let's talk about the infamous palmaris longus, PL, the muscle everyone checks for.
Ah, yes. The variable muscle. The one that makes anatomy students immediately check their own wrists.
Do it now.
Me too, reflexively. The palmaris longus is known for its high variability. It can be small, large, or completely absent in, up to maybe 20% of the population? Maybe even more, depending on the study.
Wow. So functionally, is it important if it's missing?
Functionally, it's considered a pretty weak wrist flexor. Its main action seems to be tensing the palmar fascia, that tough layer in the palm of your hand.
So losing it doesn't cause a major deficit?
Generally, no. It's often harvested for tendon grafts precisely because its absence causes minimal functional loss.
And if you want to check if you have it, the testing technique is fascinating. It really makes that tendon pop.
It does. You flex your wrist slightly, and then you tightly pinch the pads of your little finger and thumb together.
Okay, like this?
Yep. If it's present, the tendon should pop up, visible and palpable, right there in the center of your wrist, usually between the FCR and SCU tendons.
Got it. There it is.
See? It's an interesting evolutionary footnote, maybe suggesting its function is somewhat redundant, given the strength of the other flexors.
Okay, and finally, the most medial muscle of this superficial layer, the flexor carpi ulnaris FCU. This one flags something important for nerves, right?
Absolutely. The FCU is a critical diagnostic landmark, especially regarding nerve pathways. Functionally, it does the opposite of the FCR in terms of deviation. It flexes the wrist, but it adducts the hand, pulling it toward the pinky side, or ulnar deviation.
So it works with FDR for pure flexion.
Exactly. It opposes the FCR's abduction, and the balance between these two is what allows for pure, straight wrist flexion or extension. If one is weak, the hand deviates.
But the really defining characteristic is its nerve supply.
That's the key takeaway here. The FCU is fully innervated by the ulnar nerve
And that's exceptional because...
because the vast majority of the other muscles in this anterior flexor-pronator compartment are supplied by the median nerve.
Ah, okay. So why is that distinction so clinically important?
Well, think about nerve injuries. If someone has median nerve damage high up, say in the arm or axilla, the FCU will likely still function because it gets its supply from the ulnar nerve.
Right.
But if the ulnar nerve is injured, perhaps at the elbow where it's vulnerable, the FCU is one of the first and most prominent muscles to show weakness or paralysis.
I see. And its tendon helps find the nerve.
Yes, its tendon is a critical guide to finding both the ulnar nerve and the ulnar artery at the wrist. They run just lateral to it.
And how do you test the FCU specifically?
To test it, you'd have the person place their pronated hand flat on a table, then ask them to flex their wrist against resistance, really focusing the movement towards the medial or ulnar side. The tendon should stand out clearly if the muscle is working. ###key. Intermediate and deep flexors. Pages 426, 427.
Okay, so that covers the superficial four. Moving past them, we encounter the intermediate layer. And Morris says this is composed of just a single but very significant muscle, the flexor digitorum superficialis, FDS.
The FDS is a functional giant, although, it's often grouped with the superficial muscles because it does originate partly from that common flexor origin and crosses the elbow.
Right.
Its position deep to those first four muscles really makes it intermediate. And in terms of sheer bulk and power among the forearm flexors, it's the largest.
And its action is primarily on the fingers.
Yes, primarily. Its main job is to flex the middle phalanges of digits 2 through 5. That's flexing at the proximal interphalangeal joints, the PIP joints.
The middle knuckle.
The middle knuckle, exactly. After that, it helps flex the proximal phalanges, the MP joints, the main knuckles, and finally, it assists in flexing the wrist joint itself.
But here's where the specialization comes in, right? The FDS is unique among the finger flexors in a particular way.
Ah, yes. What's really fascinating here is its biomechanical independence. The source material highlights that the FDS is capable of flexing each finger it serves independently.
Meaning you can bend one middle knuckle without bending the others.
Precisely. Think about the incredible dexterity required for a musician, a guitarist playing chords, or a pianist hitting individual notes. That ability to move one finger at the PIP joint without the others following along, the FDS is the muscle that makes that independence possible. It's really core to our skilled grip and manipulation.
That's amazing. And anatomically, it has that really famous, or maybe infamous, relationship with the neurovasculature passing into the forearm.
Absolutely critical relationship. We mentioned nerve pathways, or potential bottlenecks. Well, the median nerve and the ulnar artery enter the main part of the forearm by passing directly between the two distinct heads of the FDS.
Two heads.
Yes, it has a large humeral-ulnar head originating from the medial epicondyle and coronoid process, and a smaller radial head originating from the radius shaft. The nerve and artery squeeze between them.
So that's a pinch point.
It's a major potential site for nerve compression. Clinicians absolutely must know this anatomical tunnel intimately.
And distally, where do its tendons go?
Distally, its 4 tendons, one for each finger, travel down the forearm. They then pass deep to the flexor retinaculum, that band across the wrist, through the notorious carpal tunnel.
Ah, the carpal tunnel.
Yep. And inside the tunnel, they're enclosed within the synovial common flexor sheath, which is like a leuconated sleeve they share with the deeper flexor tendons.
Okay. So that brings us to the final, deepest layer. The source lists 3 muscles here that really finalize fine manipulation.
Right. In the deep layer, we find the true specialists. First, there's the flexor digitorum profundus, FDP.
Profundus meaning deep.
Exactly. This muscle lies deep to the FDS, and it is the only muscle capable of flexing the distal phalanges, the DIP joints, the very tips of your fingers.
So FDS bends the middle knuckle, FDP bends the tip.
That's the primary distinction, yes. FDP gives us the power to truly hook onto something or make a tight fist. It shares that common flexor sheath in the carpal tunnel with the FDS. But functionally, and importantly, innervationally, it's distinct.
Distinct because, this is the one with the dual nerve supply, isn't it?
Precisely. It's the classic example. The medial half of the FDP, the part that flexes the little and ring fingers, is supplied by the ulnar nerve, just like the FCU.
Okay.
But the lateral or radial half, which flexes the index and middle fingers, is supplied by the anterior interosseous nerve, AIN, which is a branch of the median nerve.
Wow. So you need both nerves functioning to flex all your fingertips properly.
That's exactly right. And it means that only very severe high-level nerve injuries are likely to completely paralyze the entire FDP muscle.
Hmm.
Usually some part retains function.
Okay, who else is in this deep layer?
We also have the flexor pollicis longus, FPL.
Collicis means thumb.
Yep, FPL is dedicated solely to the thumb. It flexes the interphalangeal joint of the thumb, the joint at the tip of your thumb. This gives us the crucial ability to press our thumb tip firmly against our fingers for pinching and gripping.
Loss of that would be devastating.
Immediately devastating to almost any kind of grasping or pinching task, yeah.
And finally, the unsung hero, maybe, the pronator quadratus, PQ.
Ah, I like that description. The PQ is indeed often overlooked. It's this small, square-shaped muscle located way down distally just above the wrist, spanning between the radius and ulna anteriorly.
But it's the main pronator, not the pronator teres we met earlier.
That's right. Despite its small size, the PQ is the functional prime mover for pronation. The pronator teres, PT, up by the elbow, is really just an assistant for power and speed. The PQ initiates pronation, especially for slow, precise, or low-power movements.
I remember the source, Moore's, also emphasizing a non-movement role for its stability.
Yes, that's a critically important secondary function. The PQ actively assists the interosseous membrane in holding the distal ends of the radius and ulna tightly together.
Why is that so important down there?
It's crucial during activities that transmit upward thrusts through the hand and wrist. Imagine catching yourself during a fall onto an outstretched hand. That force slams up through the radius. The PQ contracts to stabilize that articulated strut against these sudden compressive forces, helping to prevent dislocation or excessive movement at the distal radio-ulnar joint. It really reinforces that connection.
Okay, so we've mapped the engine for grasping and pronation in the anterior compartment. Let's flip the forearm over now to the posterior compartment. This houses the muscles responsible for the opposite actions, extension and supination.
Right. And this entire compartment is somewhat simplified, at least neurologically, by one consistent rule. Every single muscle back here is innervated by the radial nerve or one of its branches.
Ah, that's a useful rule. So if you see problems with extension or supination, the radial nerve is immediately suspect.
It's the primary suspect, yes. It's a foundational diagnostic tool. If you have complete loss of wrist and finger extension and supination, you know the problem lies somewhere along the radial nerve's path.
And like the anterior side, this compartment is also organized into layers.
It is, typically described in superficial and deep layers. Though sometimes thinking about them in functional groups, wrist extensors, finger extensors, thumb muscles can be just as helpful for understanding how they operate together. Figure 3.62 gives a good overview. ###AWEF, superficial extensor muscles. Pages 427-4322. Okay, starting superficially and again sort of working our way across, we begin with the most proximal and lateral muscle, the brachioradialis, BR.
Now wait, brachioradialis, that sounds like an arm muscle, and it's in the posterior compartment, but doesn't it flex the elbow?
You've hit on all its quirks. Yes, despite being located in the posterior extensor compartment anatomically and being innervated by the radial nerve like all the others back there, its primary action is actually elbow flexion.
Okay, that's weird.
It is a bit weird. It's most effective as an elbow flexor when the forearm is in a neutral midway position, like holding a hammer, sometimes called the beer drinking position.
Huh, got it.
And notice its origin. It doesn't arise from the common extensor origin on the lateral epicondyle with most of the others. It comes from much higher up, from the lateral supraepicondylar ridge of the humerus.
I always think of the brachioradialis as kind of bridging the gap between the arm and the forearm.
Yeah.
And topographically, it's a critical landmark, right, for the cubital fossa?
Yeah, absolutely. It forms the lateral boundary of the cubital fossa, that triangular space on the front of your elbow. Super important landmark.
Okay, so after that functional oddball, we move to the primary wrist extensors, extensor carpi radialis longus, ECRL, and extensor carpi radialis brevis, ECRB.
Right. Now we're into true extension. These two are named perfectly for their insertion. Carpi at wrist, radialis radial side, and action, extensor. They extend the wrist and also abduct or radially deviate the hand, pulling it towards the thumb side.
So they work with the FCR on the front for radial deviation.
Exactly. But why are they so essential to everyday function, beyond just lifting the back of your hand up?
You hinted at this earlier with gripping.
Yes. They are critical synergists, especially the ECRB, which inserts more centrally on the base of the third metacarpal and is often considered the stronger and more functionally central player in wrist extension.
Synergists for grip.
For any powerful hand grip. Try this. Make a really tight fist, but let your wrist completely flex forward as you do it.
Okay. Yeah, feels weak and awkward.
Right.
Right.
Your flexors are so powerful, they just pull your hand into useless flexion. Now try making that tight fist again, but consciously keep your wrist slightly extended or straight.
Much stronger. Feels solid.
That's the ECRB and ECRL working. They contract to stabilize the wrist in that slightly extended position, creating a rigid platform like locking down a vice grip from which your powerful finger flexors, FDS and FDP, can exert maximum force. Without these wrist extensors counteracting the flexion pull, your grip strength plummets.
Wow. So the wrist extensors are literally the foundation of a power grip. That's crucial. How do we test, say, the ECRL specifically, since there are two?
To try and isolate the ECRL, you need to focus on both extension and abduction. So you'd ask the patient to extend and abduct their wrist, pull it back in towards the thumb side, while their forearm is held in pronation, usually against some resistance. That specific combination helps bias the action towards ECRL.
Got it. Moving medially again, we get to the digital extensors, the main extensor digitorum.
ED sends tendons to extend digits 2 through 5, the index, middle, ring, and little fingers at the MP and IP joints.
And the specialized extensor digiti minimi.
EDM is focused exclusively on extending the little finger, digit 5. It gives the little finger some independent extension capability.
Do they always work together?
They often do, but the EDM can be isolated. To test the EDM specifically, you'd ask the patient to extend only their little finger against resistance, while you hold their other fingers, 2 to 4, flexed at the main knuckles, the MP joints. That helps isolate the EDM's action.
Clever. Okay, the final superficial muscle is the most medial one on the back, the extensor carpi ulnaris ECU.
The ECU basically mirrors the flexor carpi ulnaris FCU on the anterior side. Its job is to extend the wrist and adduct the hand, pull it towards the pinky side, or ulnar deviation.
So it works with the FCU for pure adduction and with the ECRL-ECRB for pure extension.
Precisely. It completes the balance needed for pure wrist extension, counteracting the abduction pull of the ECRL-ECRB, and just like its radial counterparts, the ECU is indispensable for stabilizing the wrist during forceful fist clenching. It works with the FCU on the front to prevent excessive radial deviation when you grip hard.
So you need both radial and ulnar deviators, front and back, working in concert.
Yeah, you absolutely do. For testing the ECU, you'd pronate the forearm and ask for a wrist extension combined with adduction, again, usually against resistance. Okay, so we have all these extensor tendons from ED, EDM, ECU, ECRL, ECRB, plus the thumb ones will get to traveling distally towards the hand. They all have to pass over the wrist joint.
And if they weren't held down somehow, they'd lift away from the bone when the wrist extends, wouldn't they? Like a bowstring.
Exactly, a phenomenon called bowstringing. It would be inefficient and probably unstable. This is prevented by the extensor retinaculum.
So this is analogous to the flexor retinaculum on the front.
Very much so. It's essentially a massive, strong thickening of the deep antebrachial fascia that wraps around the back of the wrist. It acts like a wide bracelet, strapping those extensor tendons down, keeping them close to the bones as they cross the joint.
Makes sense. But doesn't that create friction, all those tendons sliding under a tight band?
It absolutely would, which is why there's another layer of organization. To ensure the tendons can slide freely and reduce that inevitable friction, they pass deep to the retinaculum within protective synovial sheaths. You can see these in figure 3.64.
Like little lubricated tunnels.
Exactly. Each tendon, or group of tendons, gets its own sheath filled with synovial fluid. This lubrication is essential, especially given the high forces and repetitive movements involved in many activities.
Okay, so the tendons are managed at the wrist, but then for the fingers, here is where the complexity of digital control really steps up dramatically. The dorsal digital apparatus or the extensor expansion.
Ah, yes. The extensor expansion, sometimes called the extensor hood. The forearm muscles, like extensor digitorum, provide the main power for extension, but the final delicate control and coordination for finger movement happens via this apparatus on the back of each finger.
So what exactly is it?
It's a remarkable feat of, well, biological engineering. As the main extensor digitorum tendon reaches the back of the metacarpophalangeal MP joint, the main knuckle doesn't just insert. It flattens out and broadens into this elaborate triangular aponeurotic sheet.
A sheet of connective tissue.
Yes, a complex fibrous sheet. This expansion is designed to distribute the extensor force precisely across both the middle and distal phalanges. It kind of trifurcates or splits three ways.
Okay.
It forms a central median band that runs down the middle to insert onto the base of the middle phalanx for extending the PIP joint, and then it gives off two lateral bands that run along the sides of the PIP joint. These lateral bands then converge further distally and unite to insert onto the base of the distal phalanx for extending the DIP joint.
Wow, okay, so one tendon from the forearm splits to control two joints down the finger.
Effectively, yes. But what's really fascinating and absolutely crucial for fine motor control is that this extensor expansion doesn't just receive input from the long extensor tendon, like ED, it also serves as the insertion point for the intrinsic muscles of the hand.
The small muscles within the hand itself, like the lumbricals and interossae.
Exactly. The interosseous muscles, dorsal and palmar, and the lumbrical muscles, insert directly onto the sides of this extensor expansion.
Why is that important?
Because their simultaneous contraction, along with the long extensor, produces a highly specialized, nuanced movement that the extensor digitorum alone cannot perform. It's often called the Z movement.
Z movement.
Yeah, think about what happens when you try to hold a piece of paper delicately or maybe make the L shape with your index finger and thumb. You need to flex the MP joint, the main knuckle, while simultaneously extending the PIP and DIP joints, keeping the finger straight.
Right, like flattening the fingers while bending the knuckles.
That's it. The intrinsic muscles pulling on the sides of the extensor expansion are what achieve this coordinated flexion at the MP joint, combined with extension at the interphalangeal joints. It's the basis of many fine motor tasks.
That collaboration explains so much. It explains why nerve damage that paralyzes those small intrinsic hand muscles, like a severe ulnar nerve injury, leads to such a profound loss of dexterity, and that characteristic claw hand posture, even if the main forearm extensors like ED are still working fine.
Precisely. The long extensors can only crudely extend everything together. The finesse comes from the intrinsic muscles modulating the action via the extensor expansion. #C. Deep and outcropping extensors. Pages 435, 437. Okay, moving finally to the deep layer of the posterior compartment. Here, we encounter muscles that specialize either in powerful supination or very specific thumb and index finger movements. The primary supinator back here is appropriately named the supinator muscle.
This sounds like the counterpart to the pronator quadratus. Is it the prime mover for supination?
It is the prime mover for slow, unopposed supination, yes, just like the PQ is for pronation. If you need fast or powerful supination, especially against resistance, the biceps brachii up in the arm becomes the main power source. But for just turning your palm up gently, the supinator does the job.
And anatomically, it's deep, right? Kind of wrapping around the radius.
Yes, it's a broad, relatively thin, sheet-like muscle located deep in the cubital fossa region, actually forming part of the floor of the fossa along with the brachialis. And it spirals obliquely around the upper part of the radius shaft.
But its main claim to fame, or notoriety, comes from its very intimate relationship with the radial nerve.
That's the critical anatomical point here. The deep branch of the radial nerve, which remember carries all the motor innervation for this entire posterior compartment, doesn't just run near the supinator. It actually passes directly between the muscle fibers of the supinator. It splits the muscle into superficial and deep layers as it tunnels through. You can see this clearly in figure 3.66.
So the supinator muscle basically forms a tight muscular tunnel for this major motor nerve.
Precisely. And as the nerve emerges distally from the supinator muscle, having passed through it, it is officially renamed the posterior interosseous nerve.
Okay, Pino.
This penetration makes the supinator a very common site for nerve compression or entrapment. Muscle hypertrophy, inflammation, or even just repetitive strain from forceful rotation can compress the PN within the supinator muscle,
Leading to
pin syndrome or radial tunnel syndrome, which typically presents as weakness in all the muscles supplied by the pin, so wrist and finger extensors distal to the supinator, but often without significant sensory loss because the superficial sensory branch of the radial nerve splits off higher up.
another case where knowing the exact branching pattern is key for diagnosis. Okay, now let's look at that group of deep muscles that seems to just pop out from under the superficial ones lower down, the outcropping muscles.
Yes, this is a great descriptive term used in Moores. It refers to the three deep extensor muscles whose long tendons emerge, or outcrop, from underneath the cover of the superficial extensors in the distal forearm to act specifically on the thumb.
And these are?
They are the abductor pollicis longus, APL, the extensor pollicis brevis, EPB, and the extensor pollicis longus, EPL.
Longus brevis, so related actions but different lengths or targets.
Exactly. These three are primarily responsible for the complex array of movements that allow us to use our thumbs with such incredible precision and opposition.
What does each one do?
The APL primarily abducts the thumb at the carpometacarpal joint, pulling it away from the palm in a plane perpendicular to the palm. The EPB extends the thumb mainly at the metacarpophalangeal (MP) joint, the main knuckle of the thumb. And the EPL extends the thumb primarily at the interphalangeal IP joint, the tip of the thumb, but also helps extend and adduct the whole thumb.
So together they control most of thumb extension and abduction.
They are the thumb's dedicated extensor abductor engine, yes. We should also mention the extensor indicis, EI here, which is another deep muscle whose tendon emerges alongside the EPL. It provides independent extension for the index finger, allowing us to point effectively.
Ah, okay. But the real claim to fame for APL, EPB, and EPL, besides moving the thumb, is the landmark they create, right?
Indeed. It's the famous anatomical snuff box. The anatomical snuff box. If you fully extend and abduct your thumb, you'll see this triangular depression appear on the radial side of the back of your wrist, right near the base of the thumb. Check it out. Figure 3.67 shows it well.
Okay. Yeah, I see it. A little hollow there.
That hollow is the anatomical snuff box, and its boundaries are formed precisely by the tendons of these outcropping muscles.
Which tendons form which border?
The lateral boundary, the one closer to your thumb tip, is formed by the tendons of the APL and EPB running together. The medial boundary, closer to your index finger, is formed by the prominent tendon of the EPL.
And why is the snuff box clinically important, besides being a cool name?
Clinicians use this space not just as a landmark, but as a critical diagnostic site. The floor of the snuff box is formed by two carpal bones, the scaphoid and the trapezium. Crucially, the radial artery also runs deep through the floor of the snuff box on its way to the hand. So if a patient falls on an outstretched hand and complains of pain in this specific area, tenderness felt deep within the snuff box upon palpation is often the first, and sometimes the only, clinical sign suggesting a fracture of the scaphoid bone.
And scaphoid fractures are notoriously tricky.
Very tricky. They are common but often difficult to see on initial x-rays and are prone to complications like non-union or vascular necrosis due to their precarious blood supply. So, snuff box tenderness is a major red flag that warrants further investigation, even if x-rays look normal initially.
All right, so we've built this incredibly intricate motor engine in the forearm, both anterior and posterior compartments. Now we need to wire it up and plumb it with the essential blood supply. The major arterial distribution begins right at the elbow, doesn't it? Where the brachial artery ends.
That's the starting point, yes.
Yeah.
The ulnar artery and the radial artery are the crucial terminal branches of the brachial artery. This bifurcation typically happens in the cubital fossa, near the level of the neck of the radius. Figure 3.68 shows this origin.
Okay, two main pipes heading down. Let's start with the ulnar artery. Which way does it go?
The ulnar artery generally takes the path of, let's say, deep complexity. It dives deep almost immediately after its origin.
Dives deep under what?
It usually passes deep to the pronator teres muscle and then continues down the forearm, running deep to the flexor digitorum superficialis, FPS, nestled between FDS and the deeper FDP. It takes a medial course down the ulnar side of the forearm.
So that deep path means it's pretty well protected.
It is for most of its course, but its branches are absolutely vital for supplying the central and deep structures of the forearm. And right away, near the elbow, it gives off important branches that form a collateral safety net.
Collateral circulation.
Yes, the anterior and posterior ulnar recurrent arteries branch off very proximally. They loop back upwards to connect, or anastomose, with branches coming down from the brachial artery around the elbow joint.
Creating a bypass.
Essentially, yes. This network of connections, these anastomoses, ensures that blood flow can continue to the forearm even if the main brachial or ulnar artery gets temporarily compressed or occluded, say, during extreme elbow flexion.
Smart design. And the ulnar artery is the main source for the plumbing going deep into the forearm itself, correct?
That's right. Fairly early on, the ulnar artery gives off a large, short trunk called the common interosseous artery. This vessel is critical because it promptly divides into the anterior interosseous artery and the posterior interosseous artery.
And these follow the membrane.
Exactly. The anterior interosseous artery travels down the front of the interosseous membrane, supplying the deep flexor muscles like FDP, FPL, PQ. The posterior interosseous artery pierces through the membrane to run down the back, supplying the deep extensor muscles. Figure 3.69 shows this branching nicely.
So the ulnar artery, via the common interosseous, takes care of the deep compartments.
Primarily, yes. The ulnar artery then continues down the forearm, eventually becoming more superficial near the wrist, where it gives off palmar and dorsal carpal branches that contribute to the arches in the hand.
Okay. Conversely then, the radial artery, does it stay more superficial?
It does. The radial artery takes a much more lateral and relatively superficial course compared to the ulnar. It descends laterally from its origin, running deep only to the brachioradialis muscle initially.
Just under brachioradialis?
Yes, and then in the distal third of the forearm, it emerges from under the edge of brachioradialis and lies quite superficially, covered only by skin, superficial fascia, and the deep antebrachial fascia. It hugs the lateral aspect of the radius bone.
Ah, and that's why it's the go-to spot for taking someone's pulse at the wrist.
Precisely. That lateral superficial course in the distal forearm, lying just lateral to the tendon of the flexor carpi radialis, FCR, and directly on top of the flat surface of the distal radius bone.
Makes it easy to feel.
Makes it very easy to palpate. That underlying radius provides a firm surface against which you can gently compress the artery to feel the pulse wave.
That raises an interesting point. Since you said the ulnar artery is often larger and gives off the common interosseous to supply the deep stuff, why isn't it used for pulse checks?
It really comes down purely to accessibility and that bony backstop. The ulnar artery, taking that deeper, more medial course, runs between muscles for much of its length. Even distally at the wrist, it's located just lateral to the FCU tendon, but doesn't have quite the same firm, flat, bony backing as the radial artery does against the radius. It's just much harder to isolate and reliably compress against a bone. So the radial artery became the standard, reliable pulse check location.
Makes sense. What are the main branches of the radial artery in the forearm?
It gives off fewer major branches within the forearm itself compared to the ulnar. There's the radial recurrent artery early on, which also loops back up to contribute to those elbow anastomoses. And then distally, like the ulnar, it gives off palmar and dorsal carpal branches that contribute to the wrist and hand circulation. Its famous continuation is into the anatomical snuff box and then forming the deep palmar arch in the hand.
And we should probably remember that general principle. Except for the superficial veins, these arteries, the deep veins, and the major nerves typically travel together.
Absolutely. They run as neurovascular bundles, often wrapped together within a common connective tissue sheath, sharing the same pathways through the compartments. It's an efficient packaging system. ## B venous drainage. Now, the venous drainage of the forearm mirrors the arterial supply in having two interconnected systems, the superficial and the deep. The superficial veins are the ones you can often see.
Right, the ones just under the skin, external to the deep fascia, traveling in the subcutaneous tissue.
Exactly. This network is highly variable, but generally includes the cephalic vein running up the lateral radial side, the basilic vein running up the medial ulnar side, and often a median antebrachial vein running up the middle of the anterior forearm.
And these often connect quite dramatically at the elbow via the median cubital vein, which everyone knows is the most common site for drawing blood.
That's the one. But the key functional detail about this whole superficial network is how it communicates with the deeper system. Throughout the forearm, there are numerous perforating veins.
Perforating means?
They literally perforate or pierce through the deep fascia, connecting the superficial veins to the deep veins lying underneath amongst the muscles.
Why is that connection so important?
It's vital because the main driving force for venous return from the limbs against gravity comes from the musculovenous pump. When your forearm muscles contract, they squeeze the deep veins running within or between them. Because veins have valves preventing backflow, this compression forcefully propels the blood upwards, back toward the heart. The perforating veins allow blood from the superficial system to get drained into this deep pumping system.
So muscle action pumps the deep veins, and the perforators let the superficial veins join in?
Got it.
And the deep veins themselves.
The deep veins are characterized by their location internal to the deep fascia and their typical arrangement. They usually occur as paired accompanying veins, the medical term being venae comitantes.
Meaning they run alongside the arteries.
Exactly. They travel alongside and usually bear the same names as the major arteries. Paired radial veins accompany the radial artery, paired ulnar veins accompany the ulnar artery, and paired interosseous veins accompany the interosseous arteries. They ultimately collect blood from the deep structures of the forearm and hand, particularly originating from the deep venous palmar arch in the hand.
So it reinforces that organizational principle we mentioned. Arteries, major nerves, and these deep vena comitantes almost always travel together in those protected neurovascular bundles.
That's the standard pattern, yes.
Yeah.
Efficient and protected.
Okay, arteries and veins covered. Now for the wiring. The nerves. The forearm acts as this dense freeway, doesn't it, for the three major nerves of the upper limb: median, ulnar, and radial.
Absolutely. And understanding their precise course through the forearm compartments and where they give off their branches dictates exactly which muscles or skin areas are affected if the nerve is injured at a particular point. This is really the cornerstone of clinical diagnosis for peripheral nerve injuries. #4L60. The median nerve.
Let's start with the median nerve. This is the main supplier of that anterior flexor-pronator compartment, right?
That's correct. It supplies most of the flexors and pronators. Its path into the forearm proper begins immediately after it crosses the elbow joint, usually medial to the brachial artery and the cubital fossa.
And its entry point is a classic site for trouble.
It is. Its entry point into the main forearm compartment is a classic site of potential clinical entrapment. It typically dives deep by passing directly between the two heads of the pronator teres muscle. Remember PT, the superficial pronator.
Yep, the power assistant. So the median nerve squeezes between its heads.
It does. And that passage can be a pinch point. Once it gets past the pronator teres, the median nerve settles into a safer plane, running down the midline of the forearm, sandwiched between the intermediate muscle layer, FDS, and the deep muscle layer, FDP. It's quite well protected there for most of its course down to the wrist. Figure 3.71a shows its path.
Okay. And its main motor branch within the forearm is the one we've already mentioned a couple of times, the anterior interosseous branch, AIN.
Yes, the AIN is a crucial branch. It typically branches off the main median nerve about, say, 4 or 5 centimeters distal to the medial epicondyle. And the key thing about the AIN is that it is purely motor. It carries no sensory fibers for the skin.
No sensation, just muscle power.
Correct. It travels down the forearm directly on the anterior surface of the interosseous membrane, between the FDP and FPL, supplying 3 vital deep layer muscles. The flexor pollicis longus, FPL for the thumb tip, the pronator quadratus, PQ for pronation initiation, and the lateral radial half of the flexor digitorum profundus, FDP, for the index and middle fingertips.
So an injury specifically to the AIN would cause...
It would cause weakness or paralysis only in those 3 muscles, resulting in purely motor deficits like the inability to make the OK sign we'll discuss later. But crucially, there would be no associated numbness or tingling in the hand because the AIN has no sensory component. That lack of sensory change is a key diagnostic differentiator when comparing AI syndrome to, say, carpal tunnel syndrome or pronator syndrome, #B, the ulnar nerve. Next up, the ulnar nerve. This nerve takes perhaps the path of maximum vulnerability, particularly as it passes around the elbow joint, where it earns its unfortunate nickname, the funny bone.
Ah, yes. Hitting that spot sends shockwaves down your arm. Where does it actually enter the forearm proper?
After passing behind the medial epicondyle of the humerus in that groove where it's easily bumped, it enters the forearm by passing between the humeral and ulnar heads of the flexor carpi ulnaris FCU muscle.
The muscle we know it supplies exclusively in that superficial layer.
Exactly. And that passageway between the heads of the FCU forms a fibro-osseous tunnel called the cubital tunnel.
Another tunnel, another potential pinch point.
Definitely. Because the nerve is relatively superficial here, easily compressed against the bone and tightly constrained within this tunnel formed by the muscle, heads, and ligaments, this is the second most common site for nerve entrapment in the entire upper limb, right after the carpal tunnel for the median nerve.
Wow, okay. So once it gets past this cubital tunnel bottleneck, where does it go?
Once safely past the FCU heads, it dives deeper and runs down the medial side of the forearm, alongside the ulnar artery, lying on the FDP muscle. And its main job here is to supply the SCU muscle itself and the medial ulnar half of the flexor digitorum profundus, FDP. You can trace its path in figure 3.71b.
It's fascinating how the FDP muscle gets split innervation. Median nerve via AIN for the index and middle fingers, ulnar nerve for the ring and little fingers.
It really is. It ensures balanced, coordinated flexion across all the fingertips. The medial aspect of the SCP, controlling the power grip involving the little and ring fingers, is powered entirely by the ulnar nerve.
And distally, the ulnar nerve gives off sensory branches too.
Yes, before it reaches the wrist, the ulnar nerve gives off crucial palmar and dorsal cutaneous branches. These provide sensation to the medial side of the palm, the entire little finger, and the medial half of the ring finger, both on the palmar and dorsal aspects. #C, the radial nerve.
Finally, the radial nerve, the commander of the entire posterior extensor supinator compartment. Where does it make its crucial split?
The main division of the radial nerve relevant to the forearm happens fairly high up, usually just anterior to the lateral epicondyle of the humerus near the elbow joint. It typically divides into 2 major terminal branches here.
Okay, what are they?
There's the superficial branch, or superficial radial nerve, and the deep branch.
Superficial sounds sensory.
It is. The superficial branch is entirely sensory in its distribution within the forearm. It runs down the lateral aspect of the forearm, initially deep to the brachioradialis muscle. Then, more distally, it emerges, becomes subcutaneous, and wraps around to the back of the wrist to supply sensation to the skin on the lateral side of the dorsum of the hand, and often the dorsal aspect of the lateral 3.5 fingers up to about the PIP joints. See Figure 3.71c.
So if this branch gets injured, say by a cut on the wrist, you'd get numbness but no muscle weakness.
Exactly. Purely sensory loss in that specific dorsal hand distribution, but no motor deficits in the forearm or hand muscles.
Okay, so the crucial motor component must be the deep branch.
That's the one. The deep branch of the radial nerve dives posteriorly, and as we emphasized earlier when discussing the supinator muscle,
It goes right through.
it penetrates the substance of the supinator muscle. As it emerges on the posterior side of the forearm, having passed through the supinator, it is officially renamed the posterior interosseous nerve.
Got it. P-time motor.
Pin motor for the extensors. The pin then continues distally within the posterior compartment, running between the superficial and deep layers of extensor muscles, and it provides the motor innervation to all the remaining muscles of the posterior compartment that weren't supplied more proximally by the main radial nerve trunk, like brachioradialis, ECRL. So it gets the ECRB, supinator self, ED, EDM, ECU, and all the deep outcropping muscles, APL, EPB, EPL, EI.
Basically everything that extends the wrist, fingers, and thumb, plus the supinator.
That's a good summary, yes.
So, putting it all together clinically, if a patient presents with wrist drop, inability to extend the wrist and fingers, but they still have normal sensation in the dorsal hand area supplied by the superficial branch.
Then you know the injury is likely affecting the radial nerve after the superficial sensory branches split off, but before or at the level where the pin innervates the main extensors. Often this points to compression of the pin within the supinator muscle, PN syndrome, or perhaps slightly more proximal deep branch injury.
But if they have wrist drop and loss of sensation in that characteristic dorsal hand patch,
Then the injury must be more proximal, affecting the radial nerve before it splits into the superficial and deep branches. This could be in the distal arm, maybe due to a humerus fracture compressing the nerve in the radial groove, or even higher up in the axilla. The level of the sensory loss combined with the motor loss is a precise map for localizing the lesion along the nerve's path. Okay, now we can really connect all this layered anatomical detail, the compartments, the muscles, the nerve pathways, to the real world of clinical problems. The forearm is constantly subjected to leverage, rotational strain, direct trauma, making the study of its common injuries and syndromes absolutely mandatory for anyone dealing with the musculoskeletal system. The clinical box section, starting on page 449, is gold here.
agreed. It really brings the anatomy to life. Hashtag HAG-A muscle and tendon pathologies. Let's start with a really common inflammatory or maybe degenerative issue related to those common origins at the elbow. Elbow tendinitis, often lumped together as tennis elbow or golfer's elbow.
Right. Lateral epicondylitis, commonly called tennis elbow, is technically the one relevant to the posterior compartment muscles we just discussed. It involves pain and inflammation, or more accurately, often tendinosis, which is degeneration, originating from repetitive strain near the lateral epicondyle.
Where the common extensor tendons attach.
Exactly. It's not always true inflammation, but often involves microtears and degenerative changes within the tendon tissue itself, particularly, it seems, in the origin of the extensor carpi radialis brevis, ECRB.
Why ECRB specifically?
Its origin is right on the front aspect of the lateral epicondyle, and it seems particularly susceptible to tensile stress during wrist extension, especially when combined with gripping and rotation. Think of the stress during a tennis backhand.
Makes sense. It's a classic overuse injury then.
Very much so. Often exacerbated by activities requiring repetitive wrist extension, maybe gripping, maybe pronation, supination, like using heavy tools, gardening, or, yes, playing racket sports. Medial epicondylitis, or golfer's elbow, is the analogous condition affecting the common flexor origin on the medial side.
Okay. Moving distally towards the fingers, we see functional losses from tendon injuries, like mallet finger. What's happening there? Figure B3.20 shows it well.
Mallet finger is a purely mechanical disruption. It typically results from a sudden, forceful hyperflexion of the distal phalanx, the very tip of the finger. The classic example is someone trying to catch a hard-thrown ball, and it hits the end of their outstretched finger, jamming it into flexion.
Ouch. And that force tears something.
It tears or ruptures the terminal slip of the extensor digitorum tendon, the very end part of the extensor mechanism, formed by the joining of the lateral bands, right where it inserts onto the base of the distal phalanx.
And because that extensor pull is now broken, the result is that characteristic posture.
Exactly. The distal phalanx just droops down and remains constantly flexed because the pull of the intact flexor digitorum profundus FTP tendon on the front is now completely unopposed. The extensor can't pull it straight anymore.
Giving it that mallet-shaped look.
Precisely. Treatment usually involves splinting just the distal interphalangeal DIP joint in full extension for several weeks, 247, to allow the torn tendon ends to heal back together without being stretched.
Okay. We also frequently encounter those soft tissue swellings, especially around the wrist, known as synovial cysts, or more commonly, ganglions. Figure B3.22 shows a typical one.
Ah, yes, ganglions. These are usually non-tender, benign, non-cancerous cystic swellings that often seem to appear mysteriously and can fluctuate in size over time.
Where do they usually pop up?
They are most commonly found on the dorsum, back of the wrist, often arising from the scapholunate ligament area. They contain a clear, thick, jelly-like mucinous fluid.
And what causes them? Where does the fluid come from?
The exact cause isn't always clear, but they often seem to arise from degeneration of the connective tissue of a joint capsule or a tendon sheath. They frequently maintain a connection, like a stalk, back to the underlying joint space or synovial sheath, allowing synovial fluid to track out and accumulate within the cyst wall.
So, while the dorsal ones are usually just a cosmetic concern or maybe cause mild aching, the location of the ganglion really dictates its clinical significance, doesn't it?
Absolutely. The clinical concern escalates dramatically if a ganglion cyst arises from the common flexor synovial sheath on the anterior palmar aspect of the wrist.
Why is that worse?
Because if this anterior cyst enlarges, it acts like an expanding mass within the already tightly confined space of the carpal tunnel. Remember, the FDS and FDP tendons run through there, along with the median nerve.
So the cyst takes up space and squeezes the nerve.
Exactly. This narrowing of the carpal tunnel due to the cyst's presence can directly compress the median nerve. This leads to the classic symptoms of carpal tunnel syndrome: pain, tingling, numbness, paresthesia in the thumb, index, middle, and half of the ring finger, and potentially weakness in the thenar muscles of the thumb. So a ganglion in the wrong place can mimic true carpal tunnel syndrome caused by other factors.
Good point. Location, location, location. Finally, let's briefly revisit a bony injury near the elbow. The fracture of the olecranon, figure B3.21, illustrates this.
Yes, the olecranon is the pointy proximal end of the ulna, the part you lean on. Fractures here are quite common, often resulting from a direct fall onto the point of the elbow.
But there's a muscle attachment that complicates things.
Critically so. The powerful triceps brachii muscle, the main extensor of the elbow, has its massive tendon inserting directly onto the olecranon process.
So when you fall, the triceps contracts.
Exactly. The impact force combined with a sudden powerful reflex contraction of the triceps frequently results in what's called an avulsion fracture. The muscle contraction literally avulses or pulls the fractured olecranon fragment away from the main shaft of the ulna.
Pulled apart by the muscle.
Yes. And because of this continuous muscular traction constantly trying to separate the fragments, these fractures rarely heal well without intervention. Operative repair, typically using techniques like tension band wiring or pleating and screwing, is usually necessary to pull the fragments back together, hold them securely, and allow the bone to heal in proper alignment. #TAG-B nerve entrapment and injury syndromes. Okay, this brings us squarely into the territory where our detailed knowledge of the nerve pathways through the forearm compartment really pays dividends. We absolutely must understand the typical clinical presentations of specific nerve entrapments to accurately localize the site of the injury along the nerve's course.
Right, it's like detective work using the symptoms as clues. Let's start with a relatively high entrapment of the median nerve within the forearm. Pronator syndrome, figure B3.26, is helpful here.
Pronator syndrome is a really critical diagnosis to be able to differentiate from the much more common carpal tunnel syndrome, which happens down at the wrist. In pronator syndrome, the median nerve gets entrapped much more proximally, typically near the elbow joint.
And the usual culprit is?
As we discussed, the nerve normally passes between the two heads of the pronator teres muscle. Compression can occur right there, possibly due to hypertrophy, enlargement of the muscle, maybe from repetitive forceful pronation activities like using tools or certain sports.
Weightlifting.
Manual labor, definitely. Or it could be due to direct trauma to the area or sometimes because of tight fibrous bands associated with the muscle origin.
Okay, so what are the telltale symptoms that point the finger specifically at this proximal forearm compression rather than compression down in the carpal tunnel at the wrist?
The key symptom complex involves pain and tenderness, specifically located in the proximal anterior forearm, often described as a deep ache. This pain is typically exacerbated by activities involving repeated, forceful pronation, like using a screwdriver or playing tennis.
Okay, pain in the upper forearm. What about sensory changes?
Crucially, because the compression occurs proximal to where the main sensory branches for the hand take off, but often distal to the branches supplying the very first forearm muscles, you typically get sensory loss plus maybe some subtle motor weakness. The patient usually experiences hyposthesia, decreased sensation, or numbness tingling in the characteristic median nerve distribution. The palmar aspect of the radial, 3.5 digits, thumb, index, middle, and half the ring finger, and the palm area over the thenar eminence.
So pain in the forearm plus numbness in the hand points towards pronator syndrome.
That combination is highly suggestive, yes. Contrast that with carpal tunnel syndrome, where the pain and numbness are typically maximal at the wrist and hand, and forearm pain is less common or radiates up from the wrist.
Got it. Now, what if the injury occurs a bit lower down in the forearm, specifically affecting only that purely motor branch of the median nerve, the AIN? That gives us a much different clinical picture. Anterior interosseous syndrome, AIM.
Right. AAN syndrome, sometimes called Kilo-Nevin syndrome, is the clinical manifestation of damage or compression specifically to that anterior interosseous nerve. And remember, the AIN is purely motor,
No sensory
or
fibers.
sensory fibers at all.
Yeah.
Therefore, if the AIN is injured, the patient experiences absolutely no numbness, tingling, or sensory loss whatsoever. Sensation in the hand is entirely normal. They only experience motor function loss in the three deep muscles supplied exclusively by the AIN.
Which were FPL, PQ, and the radial half of FDP.
Correct. Flexor pollicis longus, thumb tip flexion, pronator quadratus, pronation, and the FDP tendons to the index and middle fingers, fingertip flexion.
And this leads to that classic clinical diagnostic sign involving the hand posture when trying to make a circle. Figure B3.25c shows this.
Precisely. The patient loses the ability to flex the interphalangeal IP joint of their thumb due to FDL paralysis, and also loses flexion at the distal interphalangeal DIP joints of their index and middle fingers due to FDP paralysis.
So when you ask them to make the universal OK sign, touching the tip of their thumb to the tip of their index finger,
Instead of forming a nice round circle with the tips, their thumb and index finger remain relatively straight, and they end up making more of a flattened pinch gesture with the pads opposing rather than the tips. This inability to make a proper OK sign due to the loss of thumb and index fingertip flexion is considered pathognomonic, uniquely characteristic of AAN syndrome.
wow. So that contrast, sensory loss and forearm pain in pronator syndrome versus pure motor loss, presenting as the abnormal OK sign in AAN syndrome, is a vital diagnostic distinction for localizing median nerve problems within the forearm.
Absolutely vital. They affect the same nerve trunk initially, but at different points and involving different branches, leading to very different clinical pictures.
Okay, finally, let's consider the specific vulnerabilities of the ulnar nerve, particularly around the elbow, leading to cubital tunnel syndrome. Figures B3.27 and B3.28 are relevant here.
As we noted, the ulnar nerve is highly vulnerable, where it passes through that tight fibro-osseous passage behind the medial epicondyle and then dives between the FCU, heads the cubital tunnel. Chronic compression here, maybe from prolonged elbow flexion like sleeping with bent elbows, leaning on the elbow, or direct trauma, leads to the second most common peripheral nerve entrapment neuropathy in the entire upper limb.
Second only to carpal tunnel. And the sensory presentation is immediately distinctive, isn't it? Different fingers affected compared to the median nerve?
Completely different distribution, yes.
Yeah.
The sensory loss in cubital tunnel syndrome is classic. Numbness and tingling paresthesia are strictly confined to the medial palm, the entire little finger, and the medial half of the ring finger. Both the palmar and dorsal aspects are usually affected because the dorsal cutaneous branch usually comes off proximal to or within the tunnel.
So the ulnar 1.5 fingers go numb. What about motor loss?
If the entrapment is severe or chronic, motor loss sets in. This severely impairs most of the intrinsic hand muscles, the small muscles within the hand, responsible for fine motor control, like the interossi and lumbricals to the ring and little fingers, the hypothenar muscles controlling the little finger, and adductor pollicis. These are largely supplied by the ulnar nerve after it enters the hand. This loss leads to weakness of grip, clumsiness, and eventually muscle wasting and the characteristic claw hand deformity.
And does the loss of the FCU muscle function high up in the forearm cause a specific deficit in wrist movement itself?
Indeed it does. Remember, the ulnar nerve supplies the FCU. If that nerve supply is lost due to compression in the cubital tunnel, the wrist loses its primary adductor, ulnar deviator.
So it can't pull towards the pinky side effectively.
Correct. As a result, when the patient tries to flex their wrist, the powerful and now unopposed flexor carpi radialis, FCR, which is still working fine because it's supplied by the median nerve, pulls the hand strongly into flexion and radial deviation toward the thumb side.
Ah, so the hand gets pulled laterally during wrist flexion.
Exactly. This visible radial deviation during attempted wrist flexion clearly demonstrates the loss of the critical balancing action normally provided by the paralyzed FCU. It's a beautiful clinical demonstration of how antagonistic muscles must work together for controlled movement.
It really underscores why understanding the precise innervation of each muscle is so essential. You don't just study what a muscle does, you have to understand what happens when it fails due to nerve injury.
That's the core of clinical anatomy right there.
It's incredible when you step back and look at it. The forearm is essentially this compact, highly sophisticated masterpiece of biomechanical engineering.
I agree.
It houses pretty much the entire operating system for the hand. You've got the power cables, arteries, the return lines, veins, the control wires, nerves, and all the motors, muscles, all cleverly arranged into these layers and compartments that permit complex rotation and fine digital control.
Yet that very complexity and density create multiple points of vulnerability, these bottlenecks where things can go wrong.
Like the cubital tunnel, the carpal tunnel, the passage through pronator teres or supinator.
Exactly. That's the perfect summary. Understanding the layered muscle groups, the concept of dual innervation, like in the FTP, the crucial stabilizing role of muscles like the pronator quadratus, and pinpointing the specific compression points for the median, ulnar, and radial nerves. That knowledge is the absolute foundation for interpreting nearly all functional deficits you'll encounter in the upper limb. The forearm truly is the critical transition zone, where raw power from the arm is translated into exquisite precision for the hand.
Well, in this deep dive, we've certainly conducted a detailed examination of the forearm. We covered the muscles of both the flexor and extensor compartments, looking at their layered organization, and we traced their complex neurovasculature following the paths of the radial and ulnar arteries and the specific courses of the median, ulnar, and radial nerves, including their critical branches like the AIN and PIN.
And hopefully, we saw how understanding this intricate anatomical framework leads directly to interpreting those vital clinical presentations. Things like differentiating pronator syndrome from AIN syndrome based on sensory findings, or understanding the widespread motor loss that occurs when the posterior interosseous nerve gets trapped within the supinator muscle. It all connects back.
Absolutely. Next time, we will finally arrive at the terminal part of the upper limb, the hand itself. We will explore its incredibly intricate intrinsic musculature, those small, specialized muscles located entirely within the hand that allow for both powerful grips and the exquisitely precise manipulations that make our hands so uniquely human.
I'm looking forward to it. Thanks for listening to Bookfulness.